Hello, I'm Dr. Michael Okun, professor of neurology, executive director at the Norman Fixell Institute for Neurological Diseases in Gainesville, Florida. Welcome to this program that's titled The Many Faces of AAV-Based Gene Therapy in Parkinson's Disease, A Look into the Future. This program is supported by an educational grant from Ask Bio Incorporated. Joining me today is my colleague, Dr. Julie Jimenez Shahed, professor of neurology and medical director of the Movement Disorders Neuromodulation at Mount Sinai in New York City. Welcome, Julie.
Thank you.
Today, we're going to discuss first how AAV-based gene therapy approaches are being applied in Parkinson's disease, and we're going to emphasize the current investigational strategies. We'd like to introduce to you the key molecular and physiological targets under study in the ongoing gene therapy trials for Parkinson's, and highlight the clinical trial endpoints we've used to assess these therapies and to summarize the most relevant emerging outcomes to date. Now, what are the current treatments for Parkinson's disease? Well, of course, we all know about oral therapies or therapies taken by mouth. So these are things like levodopa. We also know about continuous levodopa infusions and oral drugs that tickle the dopamine receptors, like dopamine agonists. We've also seen folks use patches. We call those transdermal systems, and sometimes even some IV types of systems. And there are other oral drugs, things like MAOB inhibitors and COMT inhibitors and amantadine and things that have been used in the Parkinson's armamentarium. Sometimes we go to surgical therapies like deep brain stimulation or focused ultrasound. And we think about the entire life cycle of somebody with Parkinson between could we use a behavioral treatment? Could we use an oral treatment? Maybe a pump. And now we're beginning to talk a lot more about gene therapies. So, what are the unmet needs in Parkinson's disease? Where we know that we have partially responsive tremor, that's one of the things that we see. We have folks that go up and down with their dopaminergic medications. We call these response fluctuations, early morning offs, wearing offs, delayed ons, unpredictable offs when they take their dopaminergic medications. Dyskinesias, and there are many different forms of dyskinesia. So it can happen at the peak of the dose or when the dose is coming on or going off. And then we think about certain symptoms that are dopamine responsive. These are things like walking, talking, thinking, speech problems, and swallowing. So these are many of the unmet needs. And when we think about unmet needs, we think about non-motor symptoms, many of which are unresponsive or less responsive to dopamine or dopaminergic-based therapies. We think of subsets of patients with Parkinson's disease who have more non-motor symptom burden, and these could be associated with a faster progression. And we think about the inability to slow disease progression, which is one of the main drivers of a lot of the research that's out there. Most of our care today remains as symptomatic. So let's talk about gene-based therapies. And when we think about a gene-based therapy, we have to think about how are we going to introduce functional genetic material into cells to try to correct defective genes or to confer on them new functions. And when we think about gene therapies for Parkinson's disease, we need to think about how we can get these into certain regions. And in Parkinson's, we often talk about the putamen, but there can be other areas that we can send these genes. We need to remember that these genes are not actually integrated into the chromosomal systems, but they can do really cool things like get the enzymes all revved up so we can get processes going. We deliver them through things called viral. The vectors bind to the cell membranes, they get into the area of interest, and they're going to make the new protein or the new enzyme. And that's going to be sort of the idea of how we're going to try to change or treat the Parkinson disease. So, the target of gene therapy has most commonly been the motor circuitry that's lost the dopaminergic innervation via degeneration of the nigrostriatal projection. Although I must point out to you that there are lots of research laboratories looking at other targets beyond the motor circuitry, but most of what we know now is in the motor system. What are the vectors? What are the carrier molecules that we use? So we use AAVs, those are adeno-associated viruses. These are small, non-enveloped, single-stranded DNA viruses. And the idea is that they have long-term transcription capacity of the cargo, what they're carrying, those sequences, and they do this episomally, meaning they're not changing the chromosomes. Also, another way that folks have accomplished this, instead of using an AAV, is using a lentivirus. Lentiviruses are enveloped. AAVs are non-enveloped. Lentiviruses are enveloped and they're retroviruses. They drive long-term expression via genomic integration. And so again, different ways that we can carry in to the brain. Now, when we think about gene therapy strategies in Parkinson's disease, we need to divide into two areas: symptomatic or disease modifying. On the symptomatic side, we're thinking about circuit modifying gene therapies. So this could be things like gene transfer of glutamic acid decarboxylase. This converts glutamate to GABA. And so it's really kind of an interesting story. So trying to change the STN from an excitatory to an inhibitory nucleus. Another symptomatic therapy could be using a dopamine synthetic gene therapy approach. How this would work is it would replenish dopamine within the putamen to try to normalize circuit activity and function. The other sort of pie in the sky things that we're thinking about are, could we get to disease modification? And I want to stress we're not at disease modification at this point in time, but people have talked about, could we deploy growth factor gene therapies? Could this modify the disease? Too early to know, but an interesting area. Gene silencing would be another area. We could downregulate things like alpha synuclein via antisense oligonucleotides and silence RNAs, or use these short hairpin RNAs. And again, the idea is that long term, we would look to see if there was a modification of the actual disease. So, Jui, tell us a little bit about the gene therapy challenges and some of the studies that we really need to keep our eyes on.
Yeah, no, thank you, Michael, for that great introduction into sort of where we are in the landscape and the opportunity that we have now to sort of see how these treatments can grow and sort of develop and affect our, hopefully positively affect our outcomes in terms of treating patients with Parkinson's disease. But you're absolutely right. I mean, we're at a point where we can talk about how to deliver these gene therapies, what potential outcomes they could have. But there remain several challenges to the actual implementation. And I think this just speaks to the fact that we need very carefully designed studies and very carefully designed outcome measures so that we really get an idea of what these can do and how safely they can do it. So, obviously, we're talking about central nervous system disease. And so we want to make sure that we are delivering the right cells or the right products into the right tissue, right? So, this is highly dependent, as we all know, in terms of all the therapies that we have, about the ability to cross the blood brain barrier. And many times we have to really just bypass that by delivering these gene therapies intracranially through a neurosurgical procedure. Now, when we talk about gene therapy, we also have to be careful about the concern about off target effects, right? So we know that we want to target a specific gene, we want to implement a certain change, but maybe some of these gene products actually have chemical properties that are toxic or may produce some other adverse effects in the cells that we're actually targeting. They could also have unintended effects. And there have been some unfortunate cases of gene therapies in other disease states where things like oncogenesis have been actually produced by introduction of a gene therapy product. There are chances, hopefully slim chances, that the new gene could disrupt the function of other genes. So we have to be careful about where we're inserting and how we're actually modifying the intended and just the normal function of a cell. And lastly, even with these adenoviral vectors, there is a potential to induce an immune response. And this is maybe something that we don't always think about very clearly or very, kind of regularly. In the case of adenoviral vectors, these may be dose dependent responses, actually. And it may depend on either a combination of innate immunity that we all sort of have and hopefully is functioning well, or it could be that there are pre existing neutralizing antibodies. And this has actually been demonstrated to be present in about 30 to 60% of the individuals of our general population. So we may not be able to see the same effects across everybody that is treated, and those aspects warrant very careful investigation as we're introducing these therapies. Now, as you mentioned, gene therapies have been actually around for a while. The idea of actually introducing new genes or modifying genes or somehow in the Parkinson space is actually not a new one. There was actually about 10 or 15 years ago a study that was looking at aromatic amino acid decarboxylase. And what they were able to show in these early gene therapy studies, they did a phase 1 study and then a long-term sort of follow-up. They were actually able to measure the fact that the aromatic acid decarboxylase expression was maintained over the long term. And initially, at least, there were some very promising results. It was improving motor scores in Parkinson's patients. This happened maybe over the course of 12 months, but then ultimately was followed by, again, worsening of symptoms. And the reasons for all of this are not exactly clear. There were some mild worsening of dyskinesias in these individuals, but ultimately, because the long-term effects were not sustained, this did not really go into future development. There was another interesting study looking at lentivirus, as you actually discussed. It was a gene therapy that was combining genes for 3 different enzymes that are involved in dopamine production. So we know that this is a clear problem in patients with Parkinson's disease. They were trying to deliver gene therapy that modified tyrosine hydroxylase, aromatic amino acid decarboxylase, and GTP cyclohydrolase. Again, some early results with intraputaminal injection of this gene therapy product, where there were some significant improvements actually in the motor scores of Parkinson's patients in the short term, 6 months as well as 12 months compared with baseline. There were some increases in dyskinesias. There were some changes in the on-off phenomena that people experienced. So we know, again, through these previous studies, that this type of therapy can be delivered safely. And I think really kind of the question is, what's the best way to kind of approach the idea of gene therapy in Parkinson's patients? Now, the good news is, even though these early studies had some modest effects, maybe not sustained in the long term as much as we would have liked, there are a number of other gene therapy studies that are actively in the Parkinson space at the moment that are recruiting subjects. These are looking at a variety of different things, including GDNF, which many of our audience may already be familiar with. There are some that are looking at modifying specific genetic defects in Parkinson's disease, like the GBA mutation, which we know is one of the more common genetic forms of Parkinson's disease. It increases the risk of Parkinson's. There, you mentioned the glutamic acid decarboxylase study, so that one is ongoing. And what's really interesting, I think, is this idea of how best to deliver it. Some of these are being delivered through intraputaminal delivery, neurosurgical procedures. Some are actually peripheral IV infusions using capsids that specifically target areas of the central nervous system. There's an intracisternal infusion study that is being done, and even an oral administration study. So we have so many different options in terms of how to deliver these gene therapies. And ultimately, these studies are going to show us which are the most effective and which are likely to produce the best results for our patients. So I do want to call your attention to one recent study that we have seen some results with. This is the GDNF study. And as I mentioned, our audience may already be familiar with GDNF. We've studied this in Parkinson's disease over a number of years. I think the studies themselves have been challenged by the way that we're delivering it, how well we're actually getting the product into the putamen. And we recently saw in a small study, a phase 1 study of patients with relatively advanced Parkinson's disease. Actually, they had 2 groups of patients. There was a milder group and then a more moderate group. But a small number of open label safety study that was performed here. Again, using an adenovirus vector. And GDNF, as we know, is one of these molecules that really supports the development and survival of dopaminergic neurons. And here, what this study was able to do using the more advanced neurosurgical techniques was to get better coverage of the putamen, actually use a higher dose of GDNF. And there were some encouraging results that were seen in patients both with mild Parkinson's disease and relatively moderate Parkinson's disease, where either the motor scores and medications were stable over the course of follow-up, or in the case of the moderate disease patients, actually some improvement. So I think these are showing us that there are not only safe ways to deliver gene therapy, but there are actually some positive outcomes that can be seen in the patients that we are looking to treat with them. So it's been really exciting to kind of watch this develop as we go along.
So when we think, Julie, about whether gene therapies are moving us toward disease modification in Parkinson disease, I think we really need to think a lot about what are the potential excitement, what are some of the things that we're thinking about that might be challenges, and certainly there's this renewed interest in disease modification, and a lot of this is stemming from the mostly symptomatic. They're mostly managing disease progression. And I think what's most important for folks to I think take home from this is that right now we're seeing symptomatic benefits of these gene therapies. We're seeing some safety signals that we can do these safely, which is pretty exciting, and that's interesting. But that we still haven't quite made it to the disease modification, type of step. What are your thoughts about that?
Yeah, I think it's an important thing to consider. I think these remain sort of in the very investigational stage, and we have to initially see, is there any kind of measurable effect? And I think before we can launch into this sort of very complex discussion of how to study disease modification, we have to see if there is evidence that the gene product itself is doing something that we would expect it to do in a more advanced population. I think also because these are maybe a little bit more risky, we want to make sure that the risk benefit profile is appropriate. And so, in many cases, with these types of approaches, we start with a more advanced population, and eventually we can study them in earlier disease states to really see how it changes the trajectory of Parkinson's disease, and potentially even modifies the biology, which I think is really, maybe the harder part of the equation here, given sort of the complexity of Parkinson's disease and the molecular changes that we know are associated with it.
Yeah, and I think that's a really a good point. Now, I know that you're the head of the Parkinson study group, and I'm interested in your thoughts about what sorts of sustained benefit are you looking for over time? What are you thinking about in your trial designs? Tell me a little bit about where you think this excitement's going to go next with the experts in the field.
Yeah, I think there are so many possibilities. So it's kind of really hard to summarize it. You talked about the different ways that you can actually implement gene therapy. You can, modify genes. You can put in new genes. You can silence genes. All these different things. And I think in the end, they probably are going to have different effects. And I think when we talk about trial design, we obviously talk a lot about things like randomized control trials and things like that. But I think that ultimately the challenge that we have is that this is a long disease process, right? I mean, we're dealing with years and potentially decades. And sometimes it's really hard to know what the long-term outcome really should be because we really have a hard time studying that in a concise and relatively short period of time. So we've talked a lot about the idea of biomarkers and what you can measure at sort of a cellular level that indicates that a biologic process is actually changing. And I think this is an area that we still need to explore more thoroughly in the case of gene therapy and whether those are actually measures that we can use to demonstrate something beyond symptomatic benefit.
Yeah, and as we sort of bring this discussion home, what resonates with me is that gene therapy has arrived for Parkinson's in the research realm, and it's getting closer and closer to a reality and something a tool that we may be able to use. And the other thing that resonates to me is we have to think about how the therapy could be woven into other medical and surgical approaches to enhance outcomes, and that's what it's all about is creating impact. And so what resonates with you, Julie, about gene therapy and Parkinson and where it's going?
Yeah, I'm really intrigued by the multiple different ways that we can do this and the different potential biochemical processes that we can impact by gene therapy. So I think the possibilities in a lot of ways are just as diverse as the disease itself. And so that I think makes it really promising and interesting to study. And I think the other thing that really resonates with me is that now with some of our newer approaches, we are able to do this safely, as we have talked about, but we need to really kind of have these long-term studies to sort of see what the ultimate effects are going to be. And I think you've alluded to that several times. It's still early days, but the promise is certainly there. And I think it's just in terms of the way that we design these studies, the way that we investigate it, and then the way that we look at it in the broader range of Parkinson's therapies.
Shuey, thank you so much for this great discussion. It's really such an interesting and potentially impactful area in Parkinson disease. And thank you for participating in this activity.